Okay, so throughout this PowerPoint presentation, we're going to be talking about breastfeeding and skin-to-skin contact. Obviously, I don't work on an obstetrics unit, but this topic was interesting to me, and after doing research, I hope to be able to present this research project to their staff and replicate it here in the hospital. So, some main points we're going to be talking about. We're going to talk about the problem of breastfeeding, why it's such a problem for mothers, a review of the literature. We're going to briefly talk about some research studies that have been done. We're going to talk about a PICO question, which for those who don't know, a PICO question is just elements of a well-formed clinical question. So there's 4 elements to a PICO. There's a problem or patient, an intervention, what that intervention is going to be compared to, and an outcome. We're going to talk about the design of a proposed research study that could be done here in the hospital, and we're going to talk about how we would collect and analyze the data. So according to the Center for Disease Control and Prevention, skin-to-skin contact improves breastfeeding rates by helping mothers begin breastfeeding early and learn infant feeding cues. In 2011, only 54.4% of hospitals in the United States had at least 90% of infants receiving skin-to-skin contact after vaginal birth. And simply, skin-to-skin contact is just the practice that places an infant on the skin of the mother on her chest within 1 hour. According to the Association of Women's Health, Obstetric and Neonatal Nurses, without the initiation of skin-to-skin contact, a newborn can experience decreased thermoregulation, prolonged time to successful first breastfeed, and overall shorter duration of breastfeeding. So without a guiding policy in place, staff members don't have an expectation of the initiation of skin-to-skin contact, what is expected of them as staff members, how quick that should happen, what circumstances may delay that. So the California Department of Public Health provides a hospital policy recommendation that states that newborns should be skin-to-skin with the mother for the first several hours after birth unless contraindicated. They say that this should also take precedence over things such as glucose sticks, eye medications, and all those kind of things. So again, without a guiding policy, skin-to-skin contact is an encouraged practice, but it's not required. We're not held accountable for it, and it can lead to poor breastfeeding experiences for both mother and baby. So briefly, we're going to talk about a review of the literature, some research studies that have been done in other places, and how those could be applicable here. There was a study in Southeast England that evaluated the effects of immediate skin-to-skin contact in the OR after elective cesarean sections. These women were between 37 to 42 weeks gestation with a desire to breastfeed. There were a total of 378 participants. There was a 5% increase in the breastfeeding rates at 48 hours for those in the immediate skin-to-skin group. So for all these studies, they were divided into immediate skin-to-skin or delay or no initiation of skin-to-skin contact. This next one was in an Iranian hospital. These mothers were 18 to 40 years old. These were, again, elective cesarean sections, full-term infants. They used an infant breastfeeding assessment tool, an IBFAT, which we'll discuss more a little bit later in detail. 52.2% of infants in the skin-to-skin contact group showed a readiness to breastfeed, compared to 25% in the routine care group. Next, in Queensland, Australia, this study was limited to vaginal births. They used a birthing observation tool. Out of 78 total births, 68% of infants began suckling within the first hour after birth. The next one in Japan, again, this one was a little bit different. They were studied 1 month after delivery. These women were 37 to 41 weeks, vaginal births only, 404 women. Women with early skin-to-skin contact showed successful breastfeeding at a rate of 59.6%, compared to 45.8% of women without early skin-to-skin contact. And lastly, this study was done in Sweden. This one again was a little bit different. These infants were 2 weeks to 5 months old. They were determined to have severe latch-on problems. So these researchers wanted to see what skin-to-skin contact would do for these mothers and infants. Within 3 weeks of skin-to-skin contact initiation, 74% of infants started to latch regularly when breastfeeding, compared to 39% in the control group. So back to that PICO question that we talked about a little bit earlier. The PICO question for this research proposal was to determine if early skin-to-skin contact between mother and baby after birth increases the success of breastfeeding compared to a delay or no initiation of skin-to-skin contact. So those 4 elements, again, the population consists of mothers and neonates after delivery. The intervention is immediate introduction of skin-to-skin contact, being compared to a delay or no initiation of skin-to-skin contact. And lastly, the prospective outcome was to determine if this intervention shows significant increases in effective breastfeeding. Design, setting, and sample. So throughout these next couple slides, we're going to be talking about the design of a proposed research study that could be done here in the hospital. It would be a quantitative experimental study on an obstetrics unit. It would consist of a control and experimental group. The infants and mothers would be divided into the control and experimental group based on their delivery method and the condition of mother and infant after birth. So the experimental group would experience early initiation of skin-to-skin contact, while the control group would experience a delay or no initiation. And reasons for that might be a cesarean section where they just can't get skin-to-skin fast enough, or an infant or mother who's in distress after birth. And early initiation would be defined as skin-to-skin contact within 5 minutes after delivery. So then the nurse would use this IBFAT to assess breastfeeding after delivery. And we're going to talk about that a little more in the next couple slides. Mothers would be required to be between the ages of 18 to 40 years old without major medical complications. They would be delivered either vaginally or by cesarean section. They would have to be between 37 to 42 weeks gestation with a desire to breastfeed. There would be an estimated number of 100 participants. I estimated this would be about 60 in experimental group, 40 in control group, again just depending on delivery method and how the condition of the mother and infant are after birth. The study would take place over 6 months. So all women who would be admitted to the obstetrics unit for delivery would get a document that describes the hospital protocol for skin-to-skin contact and breastfeeding using that IBFAT tool, and they would also get a document that describes the reasons that skin-to-skin may be delayed, just so they know what to expect. So after we have all this in place, how would we collect this data? We would use the IBFAT, that infant breastfeeding assessment tool. It was first developed in 1988 and has been used in numerous research studies. The IBFAT measures the infant based on 4 things: a readiness to feed, rooting, fixing or latching on, and sucking pattern. So a score from 0 to 3 is given for each category based on specified criteria with a total maximum score of 12. So I won't break down each of these categories, but this is a sample of the IBFAT. They are measured on, again, the readiness to feed, the rooting, the fixing, and the sucking pattern. They get a score from 0 to 3. You can see they get a 3, like if you look at sucking pattern, if they suck well on both breasts. They get a 0 if they did not suck at all. Again, a total maximum score of 12. So after we collect this data, how would we analyze it? We would use an unpaired t-test to compare the differences between the control and experimental group. Again, we would be looking at comparing the skin-to-skin contact IBFAT scores versus the IBFAT scores of participants who experience a delay or no initiation of skin-to-skin. Lastly, in conclusion, the initiation of skin-to-skin contact is vital for both mother and baby to establish a successful relationship in regards to breastfeeding. It is an encouraged practice, but we don't have specific policies in place regarding it. Without clear guidelines, our staff members do not have an understanding of the expectations regarding initiation of skin-to-skin, which leads to a decreased quality of care for both mother and baby after birth. Research needs to be conducted to establish best practice and policies for skin-to-skin related to breastfeeding success. After analyzing this data and creating guidelines for facilities to follow, both mother and baby would experience the numerous benefits of skin-to-skin contact and could show significant improvement in breastfeeding rates. And lastly, we're to the references, so questions or comments. Anyone? Great job. I'm very important.
So who's going to be grading